And I want you to think about this in a minute, okay? The World Health Organization has talked about universal health care, right? If you read any of the World Health Organization's efforts in the last many months, it's been about universal health care around the world. Every country, every community, universal health care. But here is a key point. Universal health care cannot happen if there is no primary health care. So the whole conversation of universal health care is predicated on the premise that you absolutely need primary health care to operate. So let's start with that, okay? The second question is, if that is the case, how are we doing? And I want to show you some slides to suggest that the US is doing horrible. We are not doing good. We can do so much better. And we'll talk about why that is and what are the challenges. And then the third point about it is, I would like to get back to a point to say, what can Udayana do? What can the Ministry of Health and the future of care of communities and populations in your country? So I would like to set it up in that way. Okay? Sounds good? Okay. So let's go back a minute and talk about the history of...
Oh yeah, bukan.
I feel awkward sitting.
Yes.
Can you hear me? Okay.
You can move around.
I'd like to go back and figure out the history of primary care, primary medicine in the US. Now, keep in mind that care of communities has always existed for centuries, long before the Europeans came to our shores, long before hospitals were created. Every community had a healer who took care of people, right? But over the years, this premise of healing got organized so that there was knowledge being codified and put together for institutions to transmit to the next generation. So when the healer died, that knowledge is transmitted to the next generation, right? So in the US, one of the things I would like to say, if I can figure out my slides, is that in the late 19th century and the 20th century, we have a lot of information of the general practitioner, somebody who went to medical school, then after medical school immediately went out to communicate to communities and see how they can take care of communities. This was the world of the general practitioner. It was varied a lot based on which medical school you went. Each medical school had a little different curriculum, syllabus, training. So my university, University of Minnesota, has had a medical school since 1871. And so we graduated doctors in 1871, and the graduates from our university were different from another university. So it was a problem, right? So in the early 20th century, there was a famous report you folks have heard. How many of you here have heard of the Flexner report?
Reflection.
It's an interesting report. I encourage you to look at it. It's a book more than 100 years ago that it was created, that talked about standardizing medical education. And believe it or not, around the world, the model we have right now of medical education, including in Indonesia, is based on that. It owes its origin to that curriculum, where you have the initial preclinical topics, anatomy, physiology, pharmacology, biochemistry, and others, and then you have the clinical topics, and then you graduate medical school. So the Flexner report has been there for a long time. I'm not saying good or bad. It had its place. Flexner report was an important one. So then in the US, what we saw after World War II was a push towards specialization. There was a recognition that we need to know more about some particular diseases, about the heart, about the lungs, about the stomach, about the brain. And what was once the world of the general practitioner became more and more specialist. As a primary care doctor, I'll tell you very clearly, I'm not against specialists. We need specialists. And we'll talk about why that is important in a minute. But the growth of specialization has continued since that time. Sometimes I think a little too much. And we'll talk about what that means. Okay? The growth of specialization that started after World War II has continued, not just in the US, but around the world. And you'll see this in various systems, various countries, where emphasis on specialization has continued, which is important, but it has forgotten communities, it's forgotten people, it's forgotten individuals, right? In the US, after World War II, there was a rapid growth of what we call the insurance movement, health insurance movement. Dr. Chitra indicated that she is interested in health economics. And in the US, whenever we talk about health economics, we talk about the health insurance movement. And I know of the health insurance movement here in Indonesia too. And we don't have time today to talk about all the challenges of the health insurance movement. I'll leave you with one nugget of information. There is a very large health group. Their last quarter profit last quarter was $7 billion US dollars.
Profit?
I'll let that sink in, okay? One quarter profit, $7 billion US dollars. We won't go into details today. I don't think we have time to go into details about the health insurance challenges and things like that. But it's an important thing in the US because the health insurance growth has continued since World War II. And it is important. Health insurance is important. But you have to ask the question, who's making the profit and why? Right? So in the US, one of the things they noticed was in the growth of specialization, it was actually a bunch of pediatricians primarily who figured out that we were getting dissociated from communities, from people. So in the late 1960s, we started having the growth of a discipline called family medicine. It was considered to be countercultural, protesting against the big universities, right? Because most big universities did not have family medicine. There are some big universities, even now, big name universities in the US with no family medicine. We call them the orphan universities. Like Harvard, New York University, Johns Hopkins, they don't have family medicine. We call them orphan universities because they still don't have family medicine. But in many other universities, in the late 60s, early 70s was the building of family medicine departments. So my university, University of Minnesota, and we'll talk about that in a minute, has had a department of family medicine and community health since the early 70s, 1971. We just, 2 years ago celebrated our 50th anniversary.
Wow.
And it's been a really wonderful experience of what are the works we have done and what it means. And we'll talk about how that can happen here in the end. The key part about the growth of family medicine is a premise of comprehensive care that is needed for individuals. So we don't look at people as, this is a heart and I'm done. I'm looking at only the eyes. I don't care about the rest of the body. Because the era of specialization led to that partialization of the human body. And what we need was a sum total generalization. And the countercultural movement, some of the people who started family medicine in the late 60s and early 70s, were very strong community activists. And that's an important tenet that has continued in family medicine to this day. Along with that, we've had this continuous push and pull of resistance to the growth of family medicine and growth of family medicine. Today, family medicine departments are there in many universities around the country, and we are a very robust discipline. So, one thing I want to talk about here, and that might be pertinent for you folks when I see people from the Balinese Family Medicine Association here, is the growth of professional organization. Keep in mind, for any discipline to survive and thrive, you need an academic home that produces the people, and you need a professional home that becomes your home. That you feel like you belong to a community of professionals. And in various places, this professional home is what nurtures the growth of the discipline. So in the US, we've had departments, which are the academic homes from the early 1970s. The American Academy of Family Physicians originally started as the American Academy of General Practice in 1947, and then eventually evolved to become the American Academy of Family Physicians. The American Board of Family Medicine was recognized in 1969, so when you graduate a family medicine training, you are now board certified. So people around the country know that you have achieved the qualifications that are necessary. And then that led to the licensure of people in family medicine. We have a wonderful organization, and I think Prof. Adi, you have heard of it, the Society of Teachers of Family Medicine, STFM, which is interesting because it brings people who teach family medicine, both for medical school and for postgraduate students. It brings them together, and we talk a lot about the importance of pedagogical models, the various ways we can take care of students, learners in the field of family medicine. And if anybody were to ask me which is your professional home, I think I'll first go to the Society of Teachers of Family Medicine. Even when I was not in academia, when I was a rural doctor, I used to go to the meetings because it felt like these were my people. Primary care research is another important thing, and I was talking to Dr. Chitra about the importance of research to show what primary care can and should be doing. And in the US, we have the North American Primary Care Research Group, which obviously includes the US, Canada, and Mexico. And they are probably the biggest, one of the biggest research enterprise for primary care around the world. Any questions?
Not yet.
Okay. Did I put the name up? I put the name up. How many of you have heard of Barbara Starfield?
Barbara Starfield, not yet.
Yeah. So Barbara Starfield was a wonderful person. She passed away about 8-9 years ago, or maybe longer, 10 years ago. She was a very short lady. She was a pediatrician out of Johns Hopkins University in the US, but she was the biggest fan of family medicine. So a lot of the work on what is primary care comes from her. She did a lot of research about the importance of family medicine, and I'll talk a little bit about that too. But it's not enough to say we are good, right? We can always say, oh, we are good, look at us, it's fantastic. But we have to show that we truly bring value. So what Barbara Starfield indicated was these 4 tenets constitute what is primary care. They call the 4 C's of primary care. The first one is first contact, as in when a person gets sick, they reach out to the primary doctor as their first contact. Right? Is that okay? Are you folks comfortable with that? There's one follow-up question that comes up is, if that is the case, what about emergency medicine? Is emergency medicine primary care? Because emergency medicine is also first contact, right? Somebody gets sick and you go to the emergency room, casualty. Isn't that first contact? Yes, right?
Yeah.
What is different between that and primary care is what follows. The second part of it, continuity. So you're not seeing the patient just for that once. You're seeing them through their lifespan. I used to have patients that I've seen for more than 10 years. I knew their stories. I used to say that some of the patients, you wake me up in the middle of the night, I could tell their story. I could tell their story not just from the medical view, but from the social. Where are they from? What kind of work did they do? What were their hopes and aspirations? What were their goals? Who else is at home with them? What was the interaction with them and their daughter-in-law? What were the challenges they were having in their mental state? Those kinds of stories you get to know when you have continuity. So, for a minute, imagine, you folks, imagine going to, let's say you're sick, right? Would you rather go to somebody you trust, somebody who you know? Because when you're sick, you're very vulnerable, isn't it?
Yeah.
You're vulnerable physically, because there is something going on. Shouldn't it be that you have to go to somebody you trust, not some random person that you've never met before, that you don't know what they're saying or you don't trust what they're saying? So the premise of continuity is our superpower. So in primary care, continuity is a critical part of taking care of people. The third one is about being comprehensive. Like I mentioned, we're not partialists. We don't take care of the ear only. We take care of the ear, the throat, the lungs, the body, the mind, the brain, all of it. So we are comprehensive in our approach. So this is where I think sometimes people push back and say, that means you're not an expert in anything. My counter to that is, you're an expert in the person. And I will challenge any of our specialist friends about the latest in research, because I want to keep up with it. If it's pertinent to our communities, to our people, we need to know what is new. What is new in brain health, what is new in heart health. I don't expect to be the full expert in it, but I need to know enough so that it is relevant to my patient care, right? So that is about being comprehensive. And then the last one is coordination. I have a patient who has got really bad lungs and he needs to be evaluated for the next procedures. I'm going to reach out to my pulmonology colleagues, my lung doctor colleagues, and say, hey, can we connect? I'm going to send you my patient and this is what's going on. That coordination is also part of primary care. Questions? Yes.
I would like to ask, so primary care in the United States, not only family medicine specialist?
Yeah, good question.
Yeah, that's the first question, because here, primary care, we don't go to general practitioners. We don't have family medicine established yet in the community, and we also have pediatrician and internal medicine, which usually, for example, most of my family will come to pediatricians right away.
Right.
So can you explain more about it? And about coordination function.
Right.
If a primary care physician is coordination, will the specialist there give back the patient to the primary care? Sometimes it's about money, like.
Well, yeah. Your first question I'm going to answer in a bit, because I have some material on that. About, is family medicine primary care? What about other specialists? And we'll talk about that. Your second point, the coordination is about co-management. It is not, I'm done with you, go see them, right?
Yep.
Now, how you do it is varies a lot. I have found that if the patients have trust in you, they will come back. So I remember I had a very complicated psychiatric patient who had significant bipolar disorder with rapid cycling. If you folks know what rapid cycling is, they get manic very fast and then drop off very fast, right? And rapid cyclists can be very difficult to treat. Part of it being they may not take the medicines. They don't like taking the medicines because medicines can dull them out a little bit. So I was coordinating with a psychiatrist, and what would happen was the psychiatrist would see them once a year, and that's it, because that's all they could see. The rest of the time I took care of this patient, and majority of times I was very comfortable with the mood stabilizers that I was using, but if something was not working, I could pick up the phone and talk to the psychiatrist. So in this case, it's the classic situation of co-management. And co-management is an essential tenet in the coordination. Okay.
So it also has to be like a commitment between you and the psychiatrist to do co-management.
Yes. Yeah. Another was a little more of a bizarre story, and please forgive me if this offends you, but I had a patient who delivered at 28 weeks, and the newborn had many problems, brain development problems, ear problems, kidney problems, and unfortunately in most countries wouldn't have survived. In the US they survived, but the first 2 years of that child's life they spent more than 250 days in the hospital, in the pediatric ICU. They were so critically ill. And the mother had to quit her job to be with the child, put a lot of stress on the family. And I was taking care of the mother, the father, and the other 2 siblings. Right? 2 years into this, the kidney is continuing to fail. The child has ongoing seizures, and the pediatric nephrologist tells the mom that the next step is a kidney transplant.
Wow.
And you, the mom, might be the best match. Okay, understand the dilemma here, right? Here's a child with multiple morbidities, not a good quality of life, and a kidney that is continues to fail, and the next step is a kidney transplant. So what would you recommend?
No, actually, the
What
best.
what is the best answer? What would you say? So as a primary care doctor there, my role was to talk to all the specialists and say, hey, pediatric neurologist, this is being planned, what are your thoughts? And her first response was, no, because the medicines they have to use post-transplant will significantly interfere with my seizure medicines, and we'll have problems. I'm having a tough time controlling the seizures right now. I talked to the lung doctor, I talked to the ear, nose, and throat doctor, I talked to the cardiologist. They were all surprised because a kidney transplant was being suggested. So as a primary care doctor, I was trying to understand the tension in the family, tension in the mother, and the specialist. And so I applied to the ethics board of the hospital and said, should we suggest kidney transplant to this child? And the answer was no. So my role then as a primary care doctor is to go beyond the individual disciplines, to be the integrator, to coordinate across all disciplines, and ask the question, what is a meaningful life? Because one of the challenges that we've faced in medicine is the premise of the ethics.
Yeah.
The provision of technology makes you think you can continue to do that. But there is a limit, isn't it?
Yep.
There is a cost. There's a societal cost. There's an emotional and a social cost. How do you balance all of that? So to your question, the role of the family doctor then is to be the true integrator, understand the science, understand the medicine, integrate it, understand the ethics, and be an advocate.
It means that technically we need also to have agreement with other specialists that we will be the co-man.
Yeah, it's a relationship building. Yeah, it's a relationship building with them.
We cannot just by our individual
Well,
private practice.
Possibly, if the patient trusts you, it's finally up to the trust, right? The relationship that you have with the patient. And in this situation, I would like to add 2 other C's that a bunch of us have gotten together to suggest. The premise of understanding the community and the context. Sometimes doing nothing is the right answer.
Yeah.
Medicine sometimes has this tendency to try to become a hero. And sometimes you have to realize that meaningful health existence is difficult if you can't only use technological methods. I know this might make you a little uncomfortable, but sometimes you have to say, it's time. Right? That's one thing we do in medicine. We say, it's time. There's nothing else we can do. Nothing else we should do. Questions? Does this make you uncomfortable? I hope it is making you uncomfortable. Okay, let me go to the next one. So, yes, I can talk till the cows come home that family medicine is fantastic, etc., etc., etc. But let me show you some studies that show what happens. This is a study actually done by Bob Phillips and others that shows better primary care delivery is lower healthcare costs. And here are two, in the axis here at the bottom, you have the primary care score, which is a calculation of how good your primary care setup in the country is, and expenditure. And as the primary care score gets better, the healthcare expenditure drops. Remember how I told you we are not doing a good job in the US? Because our primary care is not good enough. We spend a whole lot more. Per capita healthcare expenditure in 1990, this is 1997, it's actually gotten worse now, was nearly $4,000. No country can afford that, right? So, one thing to keep in mind, if you're looking at the health of the community, health of Bali, health of Indonesia, you need to get the primary care score higher because the cost of care drops down significantly. And this is not just by saying you're denying care. Okay, I would actually make a case you're actually improving care because you have better access, more people come to see you, etc., etc. Right? So then, let's do one more. If I can figure out how to do this. Yes. What about quality? Because people immediately push back and say, that's cost. What about quality? And this is interesting because if you look at the outcomes indicator by reverse ranking, as in, if you're 1, it's better, right? If you're 1, it's better. If you're 9, it's worse. And the primary care ranking, again, lower the number the better, higher the number the worse. So look at these countries, and I know this is all developed countries because this is where we have the data, and I actually make a case that this data will be probably much more starker in low and middle income countries. Because we should be thinking about cost of care much more carefully than some of the high income countries, right? So here, UK, Denmark, Netherlands, Finland, etc., etc., etc. Look at what the US is. Outcomes indicator is a 9 out of all of these, and primary care rank is 12. If you look at this, this is more or less a linear graph here, right? So if you were to put a line in between in the middle, so the better outcomes is when you have better primary care. There's good data that suggests that hypertension management done in primary care is better than hypertension management done by cardiologists. I love cardiologists, don't get me wrong. Some of my best friends are cardiologists. Nothing against them. But we sometimes have a tendency to think that more specialization is better. Cardiologists have a role to play, but hypertension management, long-term management of chronic diseases are much better in primary care. Diabetes management is better in primary care than with endocrinology. I'm willing to challenge people. So sometimes, even within the medical field, we get caught up on the idea that because it is hypertension, it needs to be managed by cardiology, right? Most cases of asthma, most cases of COPD should be managed in primary care. Is there a role for specialists? Absolutely. For those outliers, more complex ones that you can co-manage with. And quality metrics will also suggest that this is true. Alright? So, next one, life expectancy. Now, this is a little busy, so forgive me. This was also work done by Barbara Starfield. So here, when the primary care physicians per 10,000 population keeps increasing, life expectancy gets better. These are different states within the US. Like those of you who know the US is very complicated. If you read all the politics news and all coming, you know how complicated it is. but each state has certain different characteristics. So down here, Louisiana, South Carolina, Georgia, Mississippi, the primary care supply is low, life expectancy is low. When you have primary care supply higher, and Hawaii and Minnesota, this is my home state, so I'm bragging a little bit here. Life expectancy is higher. Now, are there other factors? Of course, those of you studying literature, research literature will say, what about confounders, etc. Sure. Even controlling for the confounders for economy and other things, life expectancy higher when you have more primary care doctors. So, I made a case that the cost of care is better, quality is better, and life expectancy is better. Now, are you sold that we need more primary care?
Yeah.
Yes? Hopefully.
Yes,
Right.
hopefully.
This is further data from other countries, per capita health expenditure based on primary care score. Again, look at this. US is an outlier in this. US doesn't do good in developed countries. So, how does the US measure? I've already mentioned those previous numbers. Some things to keep in mind. One is the supply of physicians in the US. This is from 2019 numbers. The total number of physicians in the US is 939,000. US population is about 270 million people. So probably about the size of Indonesia. Indonesia is what, 320 or so?
People?
320 million?
Yeah, they are
So little less than the size of Indonesia, but we have 939,000 physicians in the US. Now, of that, family medicine is 118, which is only 13% of the population. And I'll tell you why this becomes important in a minute, okay?
Google.
So, Bob Phillips and others did this beautiful study. It's not an old study, 2021. If you look at building professionals, medical professionals, and see what happens to outcomes, the only profession that improves outcomes is primary care. Primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. The only one. What this means to say is, if you increase the number of cardiologists, do we need cardiologists? Absolutely. If you increase the number of neurosurgeons, do we need neurosurgeons? Absolutely. They don't make a significant dent in population outcomes. So if you are looking at the whole of Indonesia, for example, and looking at improving the health of the country, health of the people, health of your families, your relatives, people from your own banjars and villages, you need more primary care. Anybody here wanting to challenge me?
Sorry, why America is not investing more in primary care?
What's happened in the US is, let me show you this slide. If you were to model various countries and look at different specialties, right? You need about 50% of all the physicians, all the healthcare providers to be primary care, 50% all the other specialties combined. This combination significantly improves costs, decreases costs, improves quality, improves access, increases equity in healthcare. Multiple studies have shown that, right? Best value, lowest cost. Currently in the US, only about 30% of the physicians are primary care, and we'll come to that in a minute. You ask the primary care and governments. And the reason in the US is, since the late 60s, the reimbursement model through the insurance-based system pays specialists better.
Same in the US.
So if you're a dermatologist, you make much more money. If you're an orthopedic doctor, you make probably about 8 times the salary of a family medicine physician. So there is a perverse incentive that is created. Economic modeling would suggest that if you pay more, people will try to get more of that position, right?
Yeah.
That is one main problem. So we have not really looked back and say, where can we contribute? The second is our factories, our academic programs, academic units, including some of the big name ones, have not taken up social responsibility as their number one. How many family physicians typically graduate out of Harvard? In a class of 200? Maybe 0? Maybe 1. Same thing with Cornell, same thing with NYU, same thing with Duke, same thing with Duke does a little better. The challenge is all the big name universities still follow the model of the reimbursement based system. So they push people into specialty professions, not looking at what needs to happen in the community. So, answer to your question, it's because of it. Yes. I'll give you another example. I was a rural doc in the US, and I used to take care of depression. I used to take up everything that came into my door, right? And if I saw a patient with depression and I spent, say, 45 minutes, I would make it a point to spend more time with them. If I spent 45 minutes and they had Mississippi Medicaid, which is one of the insurance provision from the state, I lost $18. By the time I calculate the overheads, how much I'm paying for the staff, right? 45 minutes depression, I lost $18. At the same time, if I took liquid nitrogen and froze an actinic keratosis, which eventually might become skin cancer, if I froze it, in 15 seconds, I made $125. So the incentive, Dr. Chitra, is that the procedure-based disciplines got paid more, and that's still a problem.
Yeah.
That's a huge problem. Questions?
Okay, any questions maybe from students?
If you do, please don't hesitate, okay? Because I know sometimes you're like, okay, this guy is talking fancy, I don't know what to ask. It's okay, please interrupt me. I'd love to hear from you.
Maybe from lecturers, from administration department, division. Yeah.
Okay, I will ask.
Perfect.
This is the 30% of physicians of primary care. Is it ideal number in US compared to the population?
Is it adequate? No.
Yes.
It's not. There are two concerns we have. One is we are not achieving the 50-50 split, right? The second, what we are seeing is the 30% retiring physicians, for them to be replaced by young doctors. Young doctors are more particular about the time they work, how much time they work and all that. So for every retiring physician, we need 1.5 replacement. So our supply of primary care is not keeping up.
So, but for our young doctor, they prefer to be a specialist or family medicine?
Yes, the 70%. Well, it depends on the university. So our university is one of the better ones. The University of Minnesota is one of the better ones in sending people to family medicine. But even our numbers are about 17%. They're very low.
17 only.
And we are the top 3 in the country to send people in family medicine. We need more. We need more family medicine physicians. Yeah.
Thank you.
You're welcome.
Good job from the government who needs to change the reimbursement system. It's really a hard job.
Have you heard of things going on in Washington, D.C.? Nothing gets done. Yeah, you're absolutely right. I think the reimbursement model is a huge problem because the specialty oriented. It is, yeah, it's a guild. They want to protect their own community. So that we don't see the change as much that we thought, right? So then to answer Dr. Chitra's question, is this question about family medicine versus primary health care, right? This is a very important question because remember I started with the conversation about the WHO talking about universal health care. Universal health care means that you need primary health care in every place, right? Now, if one of the richest countries in the world, in this case the US, is not able to supply family medicine to keep up with the populations, and trust me, we are trying our best as academic units of family medicine to create more, but we won't be able to make up that numbers, right? So then, who delivers primary health care? Is it only physicians? And what kinds of physicians? And in the US, there is a little bit of a tension between some disciplines, particularly internal medicine and pediatrics, and something called med-peds, where they do training in medicine and pediatrics, as primary care doctors. And some of them do primary care work, but the training is not primary care. The training is still hospital-based, what they say, hunting zebras. The US has a term called hunting zebras, which means that when you hear hoof marks, instead of thinking of a horse, you think zebra. So they are out there looking for rare diseases rather than what is commonly present in the community. So one challenge we have is when you have, and I have some wonderful friends who are medicine doctors, pediatric doctors, they do primary care work, but they don't have the training of the comprehensive nature that is needed to take care of everything. So as a family medicine trained doctor, I was very comfortable in sports medicine, very comfortable with behavioral health, psychiatry, very comfortable in inpatient, very comfortable in obstetrics, very comfortable in adult medicine or pediatrics. And I knew when to refer because my training covered all of that. Whereas a medicine doctor, they don't see anybody below the age of 80. They're not comfortable with sexuality. And adolescent health, sexuality is a huge part of the conversation. They're not very comfortable. They typically don't get huge training in behavioral health and psychiatry. So then that's another problem. Because they're so hospital oriented, disease oriented, not community oriented. There is a huge problem. The second point is, what about other professionals? And the WHO today will tell you that they are more interested in non-physicians delivering primary care. It's a very important consideration for us to keep in mind. And Prof. Adi was, and Dr. Ariani was at the Wonka conference in Sydney. And a lot of the Wonka people express their frustration with the WHO about how they don't understand family medicine. I don't agree with that. I think they understand family medicine. They completely understand family medicine, but they're also realistic that family medicine supply can't keep up with the demand that is needed in communities. So while family medicine is true essence of primary care, primary health care is about extending care to communities. And when we don't have enough physicians, what do we do, right? So this is where I think the important thing is that the WHO interest is about the care delivery. Today, in my home state of Minnesota, which is one of the more well-off states in the US, where there's a lot of emphasis for primary care, by 2030 we'll be short of 1,800 family physicians. 1,800 family physicians more needed in my state alone. And our university graduates about 55 family medicine and postgraduate trainees every year. We won't make up that. Then we need to look at better care models. The better care models is a care delivery about using extenders, community health workers, nurse practitioners, physician assistants, and others, where they extend your care. Not substitute, this is I think a critical point. They don't take all your functions, but they are there to extend out in the communities. So I think the essential difference between primary care and primary health care is this. And we need to figure out new models of care. I'll give you an example. After COVID, one of the biggest challenges in the US is mental health, right? Not just in the US,
Yes.
in various parts of the world. And the US cannot keep up with the demand for psychiatric services. We just cannot. And we continue to try and see, hey, can we fit it in? We just cannot produce enough psychiatrists to take care of the mental health issues. But then we have to ask the question, should we change the model of care? Should we look at community psychiatry? Should we look at community psychology? Should we look at social network activation rather than medication approaches to depression? Now, don't get me wrong, I teach primary care psychiatry as a course. Medications are important, but they are limited in terms of efficacy for communities. So should we do both? So the new care models, and I'm thrilled that Dr. Chitra is interested in researching new care models and economy. This will be something to keep in mind. How do we go beyond a physician-only model? And I think as physicians, and this is where Prof. and Dr. Aryani, I think where Wonka is getting it wrong, is they're trying to push family medicine so much. And I have friends at the WHO who tell me that Wonka doesn't get it. Because they are so much about family medicine that they refuse to see that we can't supply enough, which is a huge problem. So. All right. I want to insert this here. What is beautiful about Bali? I don't have to tell you folks. You know what is beautiful about Bali. The Balinese people are wonderful. The food is amazing. The sunlight, oh my God, the sunlight. I come from Minnesota. I just talked to my wife this morning. We just started our first snow. It gets cold. Prof. Sri's son is studying in Minnesota right now. It is 0 degrees. And 0 degrees is good. When it gets minus 25, we look forward to 0 degrees.
Yeah.
So I don't have to tell you folks what is great about Bali, right? But one thing that I'm really looking at global health programs, research programs, etc., etc. But the Banjar concept, there are equivalents to Banjar in other places, but not as strong. And I know it's a cultural concept. And I know it's been around for a long time, but it is an active concept. So I'll give you a couple of examples. Through my Center for Global Health and Social Responsibility we work on an island in Lake Victoria. If you folks remember your geography, Lake Victoria is in the middle of East Africa, surrounded by Tanzania, Uganda, and Kenya. On the Kenyan side, there is an island called Mufungano Island. Okay? It's a fascinating island because Mufungano Island is a place where a lot of people go to fish, commercial fishing. There is this special fish called Nile perch that was introduced illegally by the British colonial administration to increase fisheries. And these fish can grow huge. It's an ecological disaster. If you're interested, you should read about the Nile perch and how it has damaged freshwater fisheries in Africa. But the Nile perch can grow huge, so there are commercial fishermen from all places who come there, which means that there is transactional sex and a very high rate of HIV. The population prevalence of HIV on that island is about 35%, which means that 1 in 3 people on that island is HIV positive. Which means that many people die, which means that the social fabric has been destroyed. You have to keep in mind that HIV should be looked at as a social disease rather than an infectious disease. It is an infectious disease, don't get me wrong.
Yes.
I'm not here to deny that it is caused by a virus, but it is what it does in communities, it destroys communities. And if you go to Mufungano Island, you see how the entire community has been destroyed. Okay, that is a background. And as we know today, the only way we can tackle HIV is adherence to treatment with HAART regimen. Right? If you stick to HAART regimen, majority of people will die with HIV, not from HIV. Does that make sense?
Yeah.
Right? I mean, it used to be that HIV was a death sentence. I remember in the early 90s, every HIV patient was a death sentence. It's just a question before when they died. And I remember when HAART started getting introduced in 1996 onwards, we started seeing survivals. I have an HIV patient who's been HIV positive for 27 years now.
27 years.
Works as a professional. Doesn't miss a day from work. Completely healthy. So management of this patient with HIV is more like how I would manage hypertension, chronic disease model, as opposed to an infectious disease. This is one of the reasons when I say HIV is a social disease, not an infectious disease. It is an infection, don't get me wrong. It's more than that. So, in Mufangan Island, what we decided was the best way for us to look at care delivery in that community is by looking at social network activation. Every community has a social network where you know people, but you don't activate them for health reasons. So we started a project in which we activated the social networks to see if that makes a difference. It significantly improved adherence to care. The stigma of HIV dropped. More people were willing to go and get treatment. And because of that, new cases dropped. Can we sustain it? I don't know. We need to stick to the plan forever till we get a vaccine or something else, right? So imagine that in your Banjars for all diseases, all conditions. How many of you here identify with a Banjar? How many of you here identify with a Banjar?
Everyone.
Everyone, right?
Everyone.
Right? Imagine activating the Banjar from a health viewpoint. Prof. Hadi has some interesting schemes to come for this, right?
Yeah.
So I personally feel as an observer from outside that Udayana is in a very critical point. I was interacting with some students earlier. I'm a true believer that primary care has one foot in medicine and one foot in public health. In the US, we don't do the public health aspect as well as we should. You guys have an opportunity to do both. Activate communities. Look at alternate models of care. Look at ways to make communities, not individuals. Individuals will get healthy, communities get healthy. So I think it's a unique opportunity here in Bali. And I'm hoping that the conversations I'm having with Prof. Adi will continue and then we can make more of that. And then we have people like Dr. Chitra who will study the economic modeling of that. Next project. It's a riot of colors. It's one of the most beautiful times. One of my friends indicated that somebody way up there, God or whoever you believe, opened up different cans of paint and threw it on the trees. That's how it works. By the way, in 2 weeks it'll all be gone. We'll start seeing everything white. Okay? So Minnesota is a state up in the northern part, the center of the country in the US, very close to Canada. So we get the cold weather a lot. We have 4 seasons. It's beautiful. I'm a big fan of my home state, so sorry if you don't like cold weather. It's one of the oldest family medicine departments in the US. Like I mentioned, it's more than 50 years old right now. It's the largest. We have 7 family medicine residency training programs right now in various parts of the state. And we just started 2 new rural programs, so it'll be 9 shortly. We have more than 100 faculty members who primarily are clinician educators who train family medicine postgraduate training and do clinical work too. And then we have researchers. We have a lot of researchers. We are the number 2 NIH ranked family medicine research unit in the US. So we do a lot of research too. So research around obesity, about community psychology, about stigma, about accessing underserved communities. So those are the typical research areas that we are interested in. So because of that, I feel that the School of Public Health, we are in a medical school, but the School of Public Health is our spiritual home. Because our work is out in the community. And whenever I see public health people, I say they are my people too. So this is about my department. And any questions? Yes.
Good morning, everybody, lecturers and friends. My name is Sakar. I'm part of public health students here in Udayana University, and I'm majoring in administrations and public policies. So, you talk about how in Bali, particularly about the healthcare in Bali.
Yeah.
Now, my question is, does community behavior take part in the primary healthcare development process in the US? Because here in Indonesia, community behavior is taking a big part of the development of primary healthcare in here. So that's the question. Thank you.
That's a wonderful question. In the US, the reflection of community behavior and how it influences public policy is not direct, it's not linear. Okay. Things get done, but it takes time. It tends to be more reactionary than proactive. So that's another problem. So, for example, one of the big challenges that people in the US talk about right now is the opioid epidemic. A lot of people being addicted to opioids. And that's a community problem. Communities are being devastated. So because of that, there was a activity. It was not, we could have done this 15 years ago. And we just waited. I think as a public policy student, you'll realize that public policy is about the narrative that you create. Data is important, data is very important, but it's the stories you say, right? So for example, if you're going to an elected representative, the stories you say is more important sometimes than the hard data. So how do you convert your hard data into stories that meaningfully impact politicians, legislators, administrators? That I think is key. And the fact that you're able to do it quickly here is a good sign. It's a wonderful sign. Yeah. Sorry, I had to come from there because I like sitting in the
Yeah. Yeah.
Is that enough for you, Scott?
Actions. I would more know how the community behavior take a part of the development process of the primary healthcare. I want to know that more in the US, how it's been progressively, how the development of the primary healthcare there.
I would answer your question in two ways. One is development of the institutions of primary health care, which takes time. And the second is actual practice of primary care. It varies a lot. So if you're in a rural area, it's more direct. You see more responsive things, particularly in what are called community health centers and federally qualified health centers. They tend to be a little more responsive. But by and large, the US models don't do a good job of understanding communities. By and large, US models are health systems focused. So it comes from a health system directive, what to do, and they do it. They're not very responsive to community needs. So, how many of you have heard